So picking up where we left off, we were describing the determinants of clearance. We reviewed dialyzer characteristics, stating that that was not a very impactful modifier of clearance, but rather blood and dialysate flow rate is the greatest factor, or the most pertinent factor to clearance. And of those two, blood flow dominates over dialysate for intermittent dialysis. Anticipating a conversation in our CRT Esquelita, it will be the reverse. The reverse will be true, where dialysate and replacement fluid flow rates are the main determinant of clearance for CRT. And then we talked about attributes of the solute as another category of determinant of clearance. Let me clarify one misstatement that I said, quoting the molecular weight of myoglobin. I overestimated it. It's around about 20 kilodaltons. Again, albumin, I stated correctly, was around 70 kilodaltons. So keep that in mind as you're assessing the capacity for clearance. That molecular weight of a solute is a major determinant of clearance. We talked about other attributes of the solute, including the volume of distribution. Large volumes of distribution and high lipid solubility would make for a poorly cleared substance, as would high protein binding. Okay. And then we briefly touched on the fact that phosphate, even though it's a relatively small solute, acts like a middle molecule because of the shell of water that it effectively carries around it. And longer dialysis times, increasing frequency would enhance phosphate clearance. And that is why daily home dialysis often allows for the patient to come off phosphate binders. Okay, so then let's go from those determinants of clearance to how do we actually measure what we've actually administered in terms of dialysis dose. So we have two, well, more than two, but let's talk about these couple of ways that we measure dialysis dose. KT over V would be where I'm sure your mind is gravitating to, but we can see that there are other parameters that would also be that could be leveraged to describe dialysis dose. Okay, so the first we'll go over is urea kinetic modeling. What does that refer to? Well, you have, as described here, a profile of BUN concentration that occurs on these 3 times per week dialysis schedule, described by this sawtooth curve, where I have a starting blood urea concentration at the start of the dialysis week that's relatively high. During the course of dialysis, that abruptly drops. The degree of drop can be quantified or can be is related to the dialysis dose, expressed as KT over V. This highlights the individual parameters that may affect dialysis dose, including the size of the patient, the time of dialysis, the actual urea clearance achieved. All of those affect this value KT over V. And in total, KT over V would predict a certain drop in your BUN concentration. The recovery in urea to the next start of the next dialysis treatment is a function of, once again, how big the patient is, i.e. the volume of distribution, and then this term G referring to the urea generation rate, which is in large part related to the protein intake of the patient, or if they're catabolic, then that could also increase urea generation. So this profile, the pre-dialysis urea concentration, the post-dialysis urea concentration, and the next dialysis urea concentration preceding the next dialysis treatment is a urea kinetic profile. okay? And we can model these changes in urea concentration, and then with that model, derive the dialysis dose, derive the urea generation. In general, what we're getting out of this urea kinetic modeling, which is done in the outpatient dialysis unit, you are using urea kinetic modeling to calculate, in reality, you're using it to calculate G, a G that would result in this predicted urea kinetic profile, as well as a V. Okay, so these G and V are really the, let's say, the outputs of the urea kinetic model. Okay, you put in blood flow, dialysate flow, and KOA, as well as dialysis time, okay, to calculate KT over V. Okay, but really the urea kinetic model derives these two parameters, the 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 effective V as well as the urea generation rate, and then you use again blood flow, dialysate flow rate, dialysis time, and KOA to calculate the numerator of this KT over V. Okay, but once again, the outputs are really G and V of the urea kinetic model. Okay, that's what urea kinetic modeling is. There are tools online that your problem set directs you to in order to see how this is actually done. It's done through, complex mathematical formula that allows one to, again, make sense of the pre-dialysis urea and post-dialysis urea that you're achieving given a certain blood flow, dialysate flow, and KOA, as well as dialysis time. Okay? In reality, we actually do not check 3 BUNs when you're doing urea kinetic modeling in the outpatient clinic. It really is a pre-BUN and post-BUN. Those are really the only things that are used to calculate both G and V. So you can use a pre and post dialysis urea concentration as well as a predicted K and T in order to back calculate G. Even though it doesn't make as much intuitive sense, it makes more intuitive sense to say, oh, I must need 3 data points in order to calculate G, because G is the rate of rise until the next dialysis treatment. That's the most intuitive way to understand how G is calculated. But you can also use the depth of fall in the urea as another way to calculate G given a certain V. Okay? Hopefully that makes sense. I don't want to mislead you and say that you get 3 urea concentrations in order to perform urea kinetic modeling. In fact, it's really the pre and post urea that is used to calculate, again, G and V. All right? Questions about that? One point I like to make is that we have this paper, the National Cooperative Dialysis Study, that really put into focus urea kinetics as a means to try to prescribe dialysis in a formal way. And it's from this study that the concept of KT over V emerged. Okay, so I'm sure we may touch upon that in some of our dialysis lectures. All right, let's move on. Okay, maybe I'll make a few more points if I hadn't gone deep enough. One of the parameters that you follow in the dialysis unit is how much protein intake the patient appears to be taking in. Again, that is going to be informed by this urea generation rate, G. It is divided by the patient's body weight, to get a normalized protein catabolic rate or protein nitrogen appearance. That is the clinically relevant term that emerges out of this calculated value G. So you're going to see PCRs or PNAs, that is coming out of G. Okay. Now, we also can use urea reduction ratio as a way to calculate the dialysis dose, all right? And the way in which you do this pre and post BUN, okay, is described here, right? We can measure this post-dialysis urea concentration at the end of the treatment. We don't actually stop dialysis. We simply lower the blood flow rate to a quite low value at the end of dialysis. We run the blood for a few seconds in order to eliminate the effect of recirculation, right? Recirculation happens when blood is flowing relatively fast compared to the flow of blood around that axis, whether it be a fistula or a graft or a catheter. When you're trying to suck blood faster than that particular axis can cooperate with, that's when you pull through already cleaned blood back into the dialysis circuit line. Okay, and so that could theoretically lower, or not theoretically, in principle, lower your post-dialysis urea concentration. So we run the blood flow quite low for 30 seconds or so. That essentially takes out any recirculation that may falsely reduce your post-dialysis urea concentration. So keep that in mind. Sometimes you're going to have to troubleshoot a URR or a KT over V that doesn't make sense. Knowing some of this methodology for sampling urea is important to ensure that you have good data, okay? Or you can explain bad data, right? We also tend to wait for about 3 minutes or so to eliminate the effect of cardiopulmonary recirculation. So cardiopulmonary recirculation always exists for fistulas and grafts. It is not a concern when you have a catheter in, but what's happening with cardiopulmonary circulation, I think we'll talk about as we describe some complications of dialysis. I do go over recirculation later on, okay? But you're trying to eliminate the effect of cardiopulmonary circulation by waiting beyond the 30 seconds, more like 3 minutes, okay? If you have a patient who has a fistula or a graft, you don't have to do that theoretically or in principle, once again, when you have a catheter in place, all right? Now, in studies, you might be measuring so-called equilibrated KT over Vs. The equilibrated KT over V refers to, if I can zoom into this very close, or zoom into that, and I were to look at what happens to the urea concentration for the first hour after dialysis, in fact, I get a bit of a rebound in that first hour of dialysis, and then I get the urea concentration progressively rising from that initial rebound. So that urea rebound is the so-called equilibrated urea concentration after intracellular urea moves to the extracellular space, resulting in that rebound because you are clearing urea more quickly than it can emerge from the intracellular space. So that rebound is a direct result of that phenomenon, okay? In practice, we never obtain equilibrated KT over Vs. That's really mostly something that's relevant as you interpret studies that have been done in the dialysis space, okay? In general, equilibrated KT over Vs, because the urea concentration increases, is going to result in a lower KT over V compared to the non-equilibrated or so-called single pool KT over V, okay? That's another word for non-equilibrated KT over V, is where you treat the urea as residing in a single pool, okay? The rebound results from the, again, shift of urea from that intracellular space to the extracellular space, okay? So that urea concentration equilibrates in that first hour because with dialysis, you lower urea concentrations more quickly than urea can diffuse outside of the cell, okay? Again, single pool KT over V is the opposite or alternative to equilibrated KT over V. We in general are using single pool KT over Vs, and single pool KT over Vs are going to be higher than equilibrated KT over Vs. Why? Because you don't have that urea rebound effect prior to the measurement of the post-dialysis urea concentration in the single pool KT over V. Okay? If we want to, keep it simple, not worry about, KT over V as a complex term, you can use simply the URR as a measure. That is the urea reduction ratio. That is the the post-dialysis urea concentration divided by the pre-dialysis urea concentration. Subtract that from 1, multiply that times 100%. You want a urea reduction ratio greater than 65% in order to achieve adequacy. Now, the advantage of urea reduction ratios are they're obviously easy. You have a pre and a post urea concentration. This is an easy percentage to calculate. However, it does not measure or does not take into account the urea clearance that is achieved through ultrafiltration. Okay, this is not captured in this formula. So that is one flaw of using urea reduction ratio. In general, the amount of urea removed by ultrafiltration is much smaller than that of dialysis. So still, it's a reasonable shorthand to look for adequacy of dialysis. In the urea generation during the dialysis treatment itself would also not be captured by the urea reduction ratio. And then dialysis frequency, we're going to talk about as another parameter or another parameter that affects dialysis dosing as we talk about standard weekly KT over V. Even the single pool KT over V or the equilibrated KT over V are not taking into account dialysis frequency. If we want to capture dialysis frequency, we have to do it through a term called standard weekly KT over V, which, as you can see, we're going to talk about in short order. Okay, so let's first talk about KT over V. Again, this emerged from this seminal study, the National Cooperative Dialysis Study, and they showed that KT over V was superior to simply post or pre-dialysis urea concentrations as a measure of dialysis dose. And that makes sense because, pre and post-dialysis urea concentrations could be affected by the nutritional state of your dialysis patient, right? You could be giving somebody a really low dose of dialysis, but if you eat no protein because you're frankly uremic, then you can have a relatively low urea concentration, even despite a relatively low dose of dialysis, okay? So the National Cooperative Dialysis Study actually looked at pre-dialysis urea concentrations as a measure of dialysis dose. And then after the study was done, the KT over V was revealed as a superior means to measure dialysis dose because it has no effect from the urea generation rate, the nutritional status of the patient, as would simply a pre-dialysis urea concentration. Okay? So what is the disadvantage of KTRV? As I mentioned, frequency and dialysis time are not really going to be, or the advantages of increased frequency and dialysis time are not going to be clearly apparent out of using KTRV as your sole factor for dialysis dosing. Longer dialysis times and frequencies allow for more clearance of middle molecules. As we said, phosphate acting like a middle molecule. Okay. We've already gone over the fact that most of the time we're measuring single pool KT over V, and the targets that we are using are somewhere between 1.4 and 1.2. Now, keeping in mind that this seminal paper, the National Cooperative Dialysis Study, it actually did not show that you should dose a dialysis of at least 1.2 or 1.4 in order to have better patient outcomes. In fact, the National Cooperative Dialysis Study showed that there were inferior outcomes only once your KTOV was falling in the 0.8, 0.9 range. So even this KTOV of 1.2 to 1.4, I have to state truthfully, is somewhat arbitrary. Okay, we don't have good evidence-based guidelines that said, gosh, you better make sure you get to a 1.2 or 1.4. The best attempt to answer this really showed a threshold effect at around 0.8, 0.9. Okay. Now we looked at whether there was clear benefit of increasing KTOV, single pool KTOV targets to as high as 1.65 through one important study called the HEMO randomized control trial, and that showed no clear benefit from going to higher single pool KTOVs of 1.65. Just need to acknowledge the fact that Bob Toto was one of the main authors of this trial. Okay. Without ultrafiltration, one can still use relatively simple inputs, that is a pre and post urea concentration, in order to calculate a single pool KT over V. And as you can see, pre and post urea concentrations would relate to urea reduction ratios. And you can take the negative natural log in order to calculate a single pool KT over V if you're not taking into account urea generation during dialysis or the urea removal through ultrafiltration. Now, if you want to count for those things, you can with a more complex term. You can see that this part of the Dow-Girtis equation, named for Dow-Girtis, who derived this formula, ultrafiltration is captured by this term. The urea generation rate is captured by this term. And this R is still relating to the urea reduction ratio. Okay, so you can see the complexity of this formula distills down to still the middle term is driven by urea reduction ratio. That is the largest driver of this calculation of single pool K2RV. This first term is capturing urea generation rates, and then urea or the dialysis dosing, the effect on dialysis dosing from ultrafiltration is captured by this term. Okay. All right, so we've already talked about equilibrated KTRV. I will simply reemphasize that the equilibrated KTRV is lower than the single pool KTRV. The average difference between the two is around 0.2. However, that difference will be smaller when you have longer dialysis treatment times. Okay, right? Because you would expect that if I'm doing slower, longer dialysis treatments, I have more time for equilibration of urea to occur when I'm doing slower and more prolonged dialysis treatments. If I'm going hard and fast, then there will be a significant discordance between ICF urea and ECF urea immediately post-dialysis, resulting in a bigger difference between single pool and equilibrated KT over V. All right, let's go now to this term standard weekly KT over V. And this allows one to compare the effect of a variety of different dialysis uh, frequencies and try to compare across modalities. This standard weekly KT or V would allow one to do that. It is not true that doing, for instance, daily dialysis is simply if I were to do daily dialysis 7 times a week, I simply add up the KT over Vs of each dialysis treatment, and that must be equal to the standard weekly KT over V. That's an oversimplification. It is not, it does not relate that way. Intuitively, if I can give you an intuition about these standard weekly KT over Vs, this would allow one to dose dialysis across different frequencies and achieve roughly the same urea concentration just prior to your dialysis. Okay, hopefully that makes sense. So if I was dialyzing, for instance, I'll do it graphically here. Standard weekly KT over V would allow me to say, okay, if I am dialyzing a patient, here's my urea, BUN, okay, and here's my time. Oops, lost it. Let's try again. Okay, here's my time. Okay, if I'm on a thrice weekly dialysis treatment schedule, I would drop my urea concentration, it would rise. I would drop it, it would rise. Obviously, the drop should be more abrupt. This is not totally accurate. Now, if I were to do 2 dialysis treatments a week, then I would need my urea concentration to drop much lower, okay, in order for me to achieve the same peak urea concentration on this twice dialysis prescription, okay? Essentially, standard weekly KTRV provides one an ability to say that if you have 2 individuals achieving the same standard weekly KTRV, even though they may be doing twice a week versus 3 times a week dialysis, these 2 individuals will have the same peak BUN throughout the week. Okay, that's what standard weekly KTRV essentially does. Okay, so let's go over a couple of concepts in this somewhat complicated figure. Okay, on the y-axis is my standard weekly KTRV. Notice 2 is a goal standard weekly KT over V that is comparable across a couple of different dialysis modalities. We'll get to that, okay? On the x-axis is my single pool KTRV per dialysis treatment, okay? So let's go over this. In a thrice weekly prescription of hemodialysis, I'm following this curve. If I follow this curve and I get a single pool KT over V of each one of those dialysis treatments of around 1.2, right? 1.1, 1.1, 1.2, I will have a standard weekly KT over V of around 2. Okay? Thrice weekly dialysis, each treatment has a KT over V of 1.2. That would be equivalent to a standard weekly KT over V of around 2. Okay. Now, if I'm doing CAPD, right, manual PD all day, no dry abdomen, I'm following essentially this continuous curve. I'm doing dialysis continuously. If you accept that a standard weekly or a weekly KTOV goal of about 1.7 is adequate for PD, that's weekly, right? If you divide by 7, you'll get each day's dialysis KTOV of around this range. Here we're at 0, 0.1, 0.2. It's really in this 0.25 range or so. That is equivalent to a weekly KT/V of 1.7. I just divide 1.7 by 7, okay? And you can see that that also lands on a standard weekly KT/V of around 2, okay? I challenge you to look at what your standard weekly KT/V is when you're doing CRT. CRT is obviously going to fit this continuous line. If you were to calculate KT/V for continuous renal replacement therapy, you should be able to do that. How would we do that? I'm not going to do the calculations, but I'm going to show you the numbers, right? In CRT, my time is going to be equal to 1,440 minutes or 24 hours. My K is going to be, depending on my effluent flow rates, somewhere around 30 mils per minute. Okay, somewhere thereabouts, depending on the effluent flow rates. My V is going to be my same V that you have, that you use for intermittent dialysis treatments. It's my total body water, right? And express it in milliliters, right? Not in liters. So if you calculate, you should be able to calculate. It's just simple math. K times T and then your V expressed in milliliters. You'll plug that number in somewhere around your single pool KT/V, and you'll find that your standard weekly KT/V for CRT is somewhere way above here. Okay. And that's why when I'm on service with you, I'm going to challenge you and say, his phosphate or her phosphate keeps dropping. Can you reduce the dose of CRT some? Should we reduce the dose of CRT some? The bicarb looks normal, the K looks normal, the phosphate you're chasing. And you might say, no, we're at 25 mils per kilogram per hour, Dr. Sam. And I'll say, well, where's the proof that you need 25 mils per kilogram per hour? Because you're telling me that an ICU patient receiving intermittent dialysis is adequately treated when you're getting a standard weekly KT/V in the ICU of only 2. Do we need this patient's, CRT labs look like they're a normal patient without any renal failure, where nothing is red, everything is in the black font? Is that necessary for the patient? So I may challenge you to think about these terms. One more term that will, or practice that will emerge from this that you need to know, you need to understand. 2 more, I'd say. I might say, okay, it's time to use nocturnal CRT, or some people call it prolonged intermittent renal replacement therapy. It has a silly name, PERT, okay? This takes over for SLED, right? We used to use the term SLED for those patients receiving CRT just at night, okay? They're not continuous anymore. They would be following this 7-time-week curve. And I'll tell you, okay, I want you to prescribe PERT for this patient. I want their labs to look, pretty good, somewhere around the CRT labs. You should be able to say, okay, Dr. Sam wants me to prescribe PERT. If I want a standard weekly KTRV to be somewhere around, I don't know, let's say 5 or 6, I should say, okay, I need to prescribe my 7 times per week PERT, and each one of those CRT or that day of dialysis dose should achieve a single pool KTRV of around 1.7. Okay, you should be able to do that. Finally, if you're prescribing home hemodialysis, this is what you decide with your patient. You say, do you want to do 4 times a week dialysis? 6 times a week dialysis? You tell me. And if I think a standard weekly KTRV is sufficient around 2, you follow that curve. If you want to do 6 times a week dialysis, I need each one of your dialysis treatments to be around 0.5 to give you this standard weekly KTRV of 2. Okay? If you say each treatment must be 0.5, right? Then you say, okay, I need to prescribe a blood flow rate and dialysate flow rate that achieves a certain K. You tell me that you want to do only, 3 hours of dialysis, if that's what you want. Your ultrafiltration rates would also determine how fast you do dialysis. So that just depends on how much your fluid your patient gains. And their V is still the same V that you should be familiar with. So you should be able to prescribe home hemodialysis and modify that according to how frequent you and the patient agree to do dialysis. Standard weekly KTRV allows you to do all of those things. Okay? Prescribe PERT, prescribe home hemodialysis, relate PD to intermittent dialysis. Any questions about standard weekly KTRV before I move it on? Okay. Now, renal KTRV is really most relevant for peritoneal dialysis, though theoretically you can calculate renal KTRVs for even intermittent dialysis patients, but we don't typically do that. We would calculate K by simply doing a timed urine collection, okay? And we calculate a urea clearance from that timed urea collection in the same way that we would calculate a creatinine clearance. Hopefully that is a formula that's very familiar to you, right? In calculating a creatinine clearance, it is simply going to be UV over P, okay? V being a flow rate of urine, right? So, mils per 24 hours, for instance, would be your V. U is your urine concentration of creatinine. P is your plasma concentration of creatinine. If I need to do this, if I want to calculate a KT over V, it's generally urea-based clearance that informs a KT over V, although in principle, you can speak of KT over Vs with phosphates and KT over Vs even with creatinine by convention. Urea is the marker of clearance that we use in the standard practice of dialysis dosing. So same formula, instead of creatinine in the urine, creatinine in the plasma, you're using urea in the urine, urea in the plasma to calculate a renal KT over V, okay? And then for your plasma urea concentration, because this patient is dynamic, right? Their urea concentration may be changing over time during that period of the 24-hour urine collection. You might use an average of the urea concentration at the start and finish of that urea clearance or collection, or that urine collection. Okay. Those numbers are going to be quite different when you're doing pre and post BUNs in a hemodialysis patient. In PD patient, this number will be relatively stable over the period of the 24-hour urine collection. Okay? All right. Predicting hemodialysis dose. All right. Now, that was, once again, measuring hemodialysis dose. Measuring hemodialysis dose is done by urea kinetic modeling in the dialysis clinic. You can also do the shorthand urea reduction ratios. You can calculate KT over Vs. You can do that with a simplified form that is essentially a logarithm of urea reduction ratio You can make it more complicated with Dow-Girda's formula, taking into account other things. And then you can also measure, measure dialysis dosing and translating that into standard weekly KT over V. Okay. Now, what about predicting hemodialysis dose, right? You need to be able to predict in order to prescribe adequate dialysis instead of just empirically starting and measuring and increasing, right? So how do we predict hemodialysis dose? So again, we know time, right? That's in minutes. We know V, which is the total body water, right? If a patient is non-edematous, that's going to be roughly 0.6 times their body weight in kilograms for males, 0.5 for females and the elderly. But don't forget, if a patient is markedly volume overloaded, they are going to have a volume of distribution that is significantly above this, right? So in that regard, you have to estimate. I think this patient is 5 kilos above their true dry weight. So their V would then be, if they're 80 kilos dripping wet, you would say, okay, this patient is an estimated 75 kilos if I were to estimate their dry weight. And so this male would have a V of 0.6 times 75, right? Which you get your answer, and then you add your 5 kilos back, right? Because that's just water that the volume of distribution is augmented by, right? Okay, so urea clearance K can be estimated either through direct measurements, right? One way to do that, remember we talked about at the start, you can measure a urea in the arterial limb, like pre-dialyzer, post-dialyzer, and then just divide that, multiplying it times my blood flow rate. That would give me one way to calculate K, the same K that feeds into the KT over V formula. I can calculate K that way or measure it, right? Okay, that's one way. I can also use the published dialyzer specifications, right? You'll get something like this. You'll look online. Remember, these are in vitro measurements, so they're idealized measurements, where, for instance, you might have blood flow rate running at 200 mils per minute, dialysate running at 500 mils per minute. Remember, we talked about if your dialysate is running at least 2.5 times my blood flow rate, 2.5 times 200 is 500, you can see that the urea clearance is essentially the same as my blood flow rate. Okay, you can see that in this. And you can see that I don't get any more bang for my buck, essentially, by cranking up on my blood flow rate, dialysate flow rate to 800. You can never go above my blood flow rate with urea clearance, okay? And even when I go to a bigger dialyzer, you can see that I'm not getting any more bang for my buck, right? Still, 200, I'm maxed out. So here's in vitro clearances that come from online resources or inserts for the dialyzer, right? So dialyzer specifications may allow me to predict a K. Remember, these in vitro clearances are going to be higher than in vivo clearances. Or you can also use the so-called KECN, which is a measure of conductance of sodium across a dialyzer. So the dialysis machine increases dialysis sodium concentration transiently and measures the movement of sodium from the dialysate to the patient, right? So what's happening when you're using online clearance measurements? The assumption is that urea, a small molecule, will act like sodium, another small molecule, right? And so it's essentially measuring the flux of sodium and using that as a marker for urea flux. So if I have blood going through the dialyzer, what happens is my dialysate, which is going counter current, QD, right? Transiently, my urea concentration, if my blood concentration here is, let's say, 100, my dialysate urea concentration is transiently increased to 120. Sorry, I said urea. Sorry, I'm looking at urea. I'm confusing you. Sorry. Let's use sodium. It's not urea, excuse me. Sodium of 140, right? Dialysate urea or sodium concentration transiently is elevated to 150. It measures the flux that occurred, right? It drops, the dialysate sodium drops across as it traverses the dialysis membrane or the dialyzer membrane. And so you can calculate the amount of drop must have a relationship between how much sodium, it must have a relationship to how much sodium actually went to the patient. And then it drops the sodium concentration to around 130 or so and measures the increase in sodium across the dialyzer. Okay? And so the flux of sodium from the patient to the dialysate is used once again to mark or measure small molecule clearance. And the assumption is that urea should act like sodium, and it kicks out a estimate of urea clearance based on that change in conductivity of dialysate as determined by sodium concentrations, okay, in the dialysate. Okay, so again, K we talked about is related to that arterial minus venous sampling of that solute divided by the arterial sampling of that solute. Even though we use urea as our standard marker of clearance, you can measure, you can calculate K for anything. K of potassium, K of phosphate. Any of those things can be calculated. Clearance can be calculated, vancomycin, whatever, myoglobin. You can use a inflow urea or inflow concentration of that solute, outflow concentration of that solute, divide by inflow, and calculate K. Okay. We again talked about dialyzer specifications already. I've given you an example. And then I've already talked about sodium movement or sodium dialysance as a way to estimate urea clearance. Okay. Moving on to access. So catheters are far too common in our patients. If you look at new dialysis starts, it's sad, but in the US, we have most patients who are starting hemodialysis with a catheter, 80%, which is really pretty crummy. Briefly, you know the non-tunnel dialysis catheters. We like that catheter to end up with its tip in the confluence of the SVC and right atrium. So depending on the size of your patient and the insertion point, you'll need differing lengths of catheters. Okay, so in a, you never make it to the right atrium with a femoral line. We just put in our longest catheter, almost never, I guess. And then if I have a right AJ, 16 centimeter, left IJ, we want roughly a 20 centimeter catheter in an average size individual. Okay. Moving to the ESRD context where we're dealing with tunnel dialysis catheters, we know that there is a higher mortality rate for these patients who are starting dialysis with a catheter. And obviously that you can't do a randomized controlled trial, so there's a fair amount of bias that's baked into this, but trying to correct for bias still seems to show an increase in mortality in patients who are starting with tunnel dialysis catheters. Now, there's a somewhat more contemporary paper that looks at this, suggesting that if you can reduce the total catheter time to, less than 3 months or so, there may not be a clear mortality difference. And then the other point that I want to make is that don't be a slave to this. Sometimes I think we over leverage this data and say, you know, this patient has a creatinine of 20 and comes into the ER with marked volume overload. We are going to medically manage this patient and hope that they don't get readmitted 3 times while we're waiting to get a functioning graft or fistula in. That to me is a wrong calculus. It absolutely makes sense to start people on dialysis with a catheter in place and accept this infection risk when you know in your heart that this patient's not going to make it for 3 or 4 months and stay out of the hospital. So don't over avoid, I would say, the tunneled line. Okay. I think we do that, especially at Parkland, where we don't have, access to surgeries, next week. It may be if you have a practice environment where you can get these grafts that can be stuck the next day placed. It might make sense to try and get these fistulas or these grafts in before putting in a line. But I just want to make that point. Okay, they have the complication of stenosis and venous thrombosis. Poor catheter flows are an unfortunate common problem. You can use TPA to open them up. Here's just a quick, solution if you want to. I'm sure you've all had experience with TPAing your lines, and then catheter infections are clearly another significant complications for which we'll talk about more in detail later. AV fistulas and AV graft, yes.
Can you do LTPA like overnight, or should we like always need to?
Nope, in the inpatient, I often say just tell the nurse to lock the catheter, label it, and keep it in until the next dialysis treatment. You don't want to obviously send somebody out with TPA in the line, though. Okay. If you know that they're going to be staying till the next inpatient treatment, you can consider that. All right, AV fistulas and grafts, you got to know your anatomy. I strongly encourage you to look at, when you do an ESRD consult, especially if you capture them before they have the needles in, look at their graft, try and decide whether this is a graft or fistula. Try to decide what is the points of inflow and outflow and name that fistula. Is it a brachiocephalic fistula, or this is a forearm loop graft, right? Instead of just saying the patient has an upper arm access. Really challenge yourself to do that, okay? So here's the normal anatomy. Here on the on the left hand of your screen, you have the brachial artery, which ties into your axillary artery. When it's in the arm, it's the brachial artery. That's the artery that sits in the groove between the bicep and the tricep. If you dig deep into this groove between these two muscles, you might even feel your pulse. Okay, that's your brachial artery. It splits typically just after the elbow into the radial artery and the ulnar artery, as we're describing here. Now, the anatomy might be different for individuals. It can split higher up, it can split lower down in the arm, but it's mostly lower in the arm where it splits. Okay, now you have this cephalic vein. The cephalic vein is this vein that goes down essentially on this thumb side of your radial bone, right? And some people, you can feel a plump artery here vein here, that would be your cephalic vein. Your cephalic vein goes all the way to the median cubital fossa, okay, where it splits into this basilic vein. That basilic vein, once again, is in this bicep tricep groove, right? More superficial, than the brachial artery. It overlies it. It's more superficial though, okay? That's your basilic vein, okay? We often use the basilic vein to make access. So you have to know the anatomy of the basilic vein. We are often using the cephalic vein. In the forearm, we're making often radiocephalic arteries, radiocephalic fistulas, okay? Here's one radiocephalic fistula. We transect the cephalic vein. We tie it in, what we call end to side, side of the artery, end of the vein. This is a radio inflow, cephalic outflow fistula. That's the forearm fistula that you see more commonly, okay? But we also commonly do brachiocephalic fistulas, okay? Where we would transect the cephalic vein somewhere here. We tie it into the brachial artery. And when you see this, the cephalic vein, muscular people is that vein that sits on top of the bicep that can really get pretty prominent. Okay, so if I transect that cephalic vein, connect it to my brachial artery, that is a common fistula, brachiocephalic fistula. Okay, you got to know this anatomy. Again, one last thing that you can see commonly is a brachiobasilic fistula, where I transect the basilic vein on the inner aspect of the arm, right? This is in this groove between bicep and tricep. I transect the basilic vein and I tie it deep into the brachial artery, brachiobasilic fistula. Usually, those brachiobasilic fistulas are also transposed, moved to the front of the arm. That's your basilic vein transposition. Basilic vein transposition is another common, that's fistula, often done in 2 stages. First, you tie the basilic vein into the brachial artery, making a brachiobasilic fistula. And then in a second stage, you move the fistula more anteriorly. That is called the basilic vein transposition. The giveaway for that surgery is a long incision scar that goes about that long on the inner aspect of the arm. If you see that, that is a clue that you've freed up that vein, moved it anteriorly, basilic vein transposition. Okay? And then if you're not, you're not limited to your normal anatomy, you can create grafts with artificial material to any one of these arteries and veins. Here would be a brachiobasilic loop graft, okay? Or a brachiocephalic loop graft, okay? You can see those. You can create other anatomies as well. You're not bounded by these limitations of where your veins sit. Okay, now you can also see some people having interesting places to access their fistula as they're using these perforating veins to create these non-incisional fistulas that are made percutaneously. Sometimes you can create fistulas with some of these inner arm veins as well, okay? So usually cephalic vein is your go-to, but with these percutaneous AV fistulas, sometimes you'll see more than one vein dilate, and since they're not tied off as you do often in your surgical approaches, and then you'll have multiple access points. Okay, you can also have loop grafts in the thigh. Questions about that anatomy? I'll finish this and get to complications of hemodialysis and stop there. Okay, complications of fistulas. Primary AV fistula failure means it never works. Okay, primary AV fistula failure. You can have a primary failure of an AV graft as well, but that is what primary failure suggests. Secondary failure is you try to intervene and you can you can get it to work, but then after a while, it fails despite interventions. That would be a secondary failure. Okay. The typical latency between the time the fistula is created and its readiness for use is around 3 to 4 months. But you can theoretically do it sooner than that, especially if you have a young, person with a very, well-developed vein. And actually, if you look at time to maturation in some of the Asian countries where there's less, obesity that creates a death problem for accesses, and there may be less diabetes, they have some maturation times of approaching around 1 month, even for fistulas. Okay. The predictive metrics that correlate with usability is a fistula that has a width of about 4 to 5 millimeters and 500 mils per minute of flow at around 4 to 6 weeks. So maybe you can sort of summarize this as like a rule of fives of some sort, right? 500 blood flow at around 5 weeks with around 5 millimeters. And that may also sort of correlate with this physical exam assessment, where if I see a fistula that is less than 5 millimeters deep, is at least 5 millimeters wide, and then have at least 5 centimeters of length to work with, then that may be ready to cannulate. Okay. You do not need the blessing of a surgeon to tell you you can access a fistula. You, as a practicing nephrologist, should be able to examine a fistula. You don't even necessarily need an ultrasound to confirm flow rates. If this has the right anatomy, you can access the fistula. That means it's wide enough, shallow enough, and long enough, you can access it. And if the flow is insufficient, all you'll have is recirculation, but you can still access it. Okay. So you theoretically don't need a ultrasound to clear a fistula. Many times it's done, but I want to tell you that you should start developing your skill as a practicing nephrologist so that when you see that patient in the dialysis unit who hasn't made it to their surgical appointment, you're not saying, oh, well, we can't access you because we haven't gotten the blessing from the surgeon. You should be able to say, we're ready to go. That looks good. Let's go. Okay. And you don't have to, send them for an ultrasound before making that call in the outpatient unit. Okay. AV graft and thrombosis happens quite commonly, unfortunately, especially with grafts. If you look at the data, a graft will thrombose 3/4 of the time. At 6 months, a graft will thrombose or need some kind of intervention because it's about to thrombose. So you can see that's a very high likelihood of having to send a patient for a declot or at least some form of balloon angioplasty of grafts at 6 months. And then at 18 months, you can see that these are actually your secondary patency rates. You can see that at, well, this is for your AV fistula. You can see that your fistulas are generally going to be working most of the time at 6 months and at 18 months. But this is really saying that, sorry, I've given you the wrong information here. Let me correct what I've said. Secondary patency, which I'm showing you here, is how common is it open at 6 months, but I had to do an intervention, right? You can usually get 3/4 of grafts to last to 6 months as long as you're intervening on them. But you can see at 18 months, half of grafts, despite attempts to keep them open, are gone. Okay, that's what this really refers to. Now, primary patency means, okay, how many grafts make it to 6 months without any intervention? You can see that it's only about 60% of grafts that make it to 6 months without any intervention. Okay, hopefully that makes sense. And then, only a third of grafts make it to 18 months without any intervention. That's what primary unassisted patency refers to. Secondary patency means it's still working with the help of interventions. Okay. So this is pretty, concerning, right? It's not good. These are not good. Secondary patency rates at 18 months. Now, thrombosis is something that we try to prevent through surveillance protocols at the dialysis units. But the truth of the matter is that in any formalized study, looking at these surveillance protocols, there is no clear benefit of doing surveillance on grafts and fistulas and intervening when you see, for instance, flow rates are dropping when compared to simply using your physical exam. Okay, so doing flow monitoring, often we do something called transonics, which is basically looking at the dilution of a bolus of saline by measuring changes in temperature as you're using this transonic device. So these have not shown improvements in patient-relevant outcomes with respect to access patency. All right. Now, what are the tools that we use? I mentioned the use of transonics, which you might say is this a form of intra-access flow monitoring. You can use just physical exam, looking for the pulsatile fistula that is banging against an outflow obstruction, for instance, looking for forearm or arm edema. Nurse will often say, I'm pulling clots, is a term that they use when an access seems to be about to fail. High access pressures, bleeding that persists for a very long time at the conclusion of dialysis, or an unexplained drop in KTRV. Those would be your clearing tools. Again, you can use a variety of access flow, including formal Doppler studies or these transonics. And if we see a drop in flow to less than 500 mils per minute for a fistula or less than 600 mils per minute for a graft, those have some correlation with a graft or fistula that's about to fail. Or if you look at drops in flow of 25% or greater compared to historic values, that can be another thing that predicts a access that's about to cause problems. Once again, I will tell you that these do not correlate with improved outcomes. Why? Once again, there's some operator dependence. When I was doing dialysis, sometimes when the patient was otherwise doing well, I would just say, let's just check it next month. Don't act. Okay. And when the reason why these are not necessarily good, intervening early, is every time you crack a stenosed area, you're really causing exposure of a prothrombotic surface. Now you've taken an endothelialized surface and you just you scratched on it, you cracked it, you made it more thrombogenic by intervening on it. So again, trying to intervene too much on an access or fistula is also bad. Okay. Dynamic pressure monitoring are also often just routinely used. This is really when it reports the access pressure in your dialysis flow sheets. Typically, they drop the blood flow rates down to 100 or 200 and then chart for you the access pressures. The rule of thumb is that your access pressure should be roughly half of your blood flow rate in a patient whose access is working well. Now, that's as long as you have normal or standard needles. Right? In a new stick, you may be using only 17 gauge needles. You would expect access pressures to be higher when you're pushing blood through a very narrow needle, right? So with standard needles, if you're running 400 blood flow and you're seeing access pressures of 200 or better, you should be reassured by that, okay? If you're running 300 pressures on a 400 blood flow, that's potentially a problem. It doesn't always mean the access is a problem. It might mean that the needles were malpositioned. So it's not always an access problem. It could be a needle positioning problem. So don't always just jump to the conclusion that if access pressures are unreassuringly high, then you need to intervene, look for other explanations as well. Static pressure monitoring, we don't really use much. I'm just going to let you read about that, but that's a historic test that was investigated as potentially beneficial, but really it doesn't get used much in the practical practice of nephrology. Recirculation may also be a clue that the access is about to fail. I think I'll end here just since my time is up. I won't go to thrombosis prevention. I'll pick up next I think tomorrow actually. Recirculation studies might be done through, you can actually get a indirect recirculation measurement through transonic flows as well. But what is often used is the measurement of urea concentrations after slowing the blood flow down. So again, at the start of dialysis, I can measure an arterial and venous urea concentration, and then I compare those values to a quote-unquote systemic sample. That would be a urea concentration with the blood flow turned down, right? Essentially, I'm getting very little clearance at that point if I have blood flow only 50 mils per minute. And so my urea concentration should be similar to my circulating urea concentration when I turn my blood flow down that low. And my recirculation can be calculated as this systemic concentration minus my arterial concentration over my systemic concentration minus my venous concentration, okay? If that parameter is higher than 5%, that suggests meaningful amounts of recirculation, and therefore perhaps I have stenosis that's developing. Okay, duplex studies can also be done. You'll have the same thresholds for concerns here as I've presented above. Okay. Questions?